Greetings. We welcome you to this third part of our guidelines in prenatal care. This educational video will be talking about current guidelines in the third trimester of your pregnancy, specifically between roughly 28 to 40 weeks. We're excited to share this information with you. In my own experience, this is the area of pregnancy that has the most interest in discussion, maybe because people are ready to be done. There's a disclaimer. It's simply this, that this educational information is not to replace that which is given to you by your healthcare provider. Please consult with him or her regarding medical advice, but this is meant to be a supplement to that. If you have concerns, please talk to your healthcare provider. If I'm your healthcare provider, please reach out to us. And if you're having concerning symptoms, severe symptoms, you should call 911 or go to the emergency department. This is a summary slide that we've used in the previous two educational models. A brief summary: prenatal care is defined as good care is constituted, I should say, by the following bullet points. Preconception counseling is an important part, especially if there's underlying medical problems or health concerns or chronic medications. Prenatal vitamins are encouraged. Regular and consistent prenatal care starting around 10 weeks, every 4 weeks up until 28 weeks. Today, or this module rather, we'll be talking about the third trimester, and we usually start to see our patients more frequently every 2 weeks from 28 to 36. Then often we start seeing you weekly or even twice weekly. The one caveat being if there's underlying chronic medical problems, oftentimes your provider may want to see you more often, especially if you're deemed a high-risk pregnancy. We've previously talked about antenatal screening, ultrasounds. We've talked a little bit about signs and symptoms of preterm labor. We'll talk about that more here in the next slide. We've previously discussed the importance of being screened for diabetes. Each time you come to your OB office, they're most likely checking your blood pressure. They may be getting a urine sample. What we're looking for there are elevated blood pressure. That could be suggestive of preeclampsia, or protein in the urine that could also suggest the same. We'll be speaking in just a moment of GBS screening, also known as Group B Strep. We'll be talking about the pros and cons of inductions, as well as current literature that may support or refute that. Episiotomies are often feared, and we'll talk about how they're avoided. Nowadays, we'll discuss different pain control options, pros and cons of cesarean sections when they are indicated, the benefits of breastfeeding, and also the postpartum exam. Reducing preterm labor. This is a slide that, this picture came out when I was in medical school 20 billion years ago, 20 years to be exact. And it was a landmark case of a surgeon doing a spina bifida repair, I think in a 22-weeker. Captured the world's attention and it's been famous ever since. And sometimes you'll see things that are fictitious, made up about it. But this just highlights the importance of good prenatal care that can help to reduce the incidence of preterm labor. One of the things that we're looking for are signs of infection. Untreated, undiagnosed urinary tract infections could increase your risk of going into preterm labor, other medical problems that aren't being properly attended to. In the previous educational slides, we've talked about the big four, as we refer to them in our office. Signs of preterm labor could include contractions, sudden gush of large amount of watery fluid, significant bleeding. We also like to make sure we have an adequate fetal movement. So I would just say this at this point in time, that if you're having cramping contractions from time to time, that's okay. But if it's getting closer together and more intense, specifically less than 10 minutes apart, going on for a couple hours, you really should consider reaching out to your healthcare provider. If directed to do so in our office, absolutely. During the day, give us a call. We'll probably have you come into the office. After hours, weekends, holidays, labor and delivery is the place to go. When you go to the ER is great, but it makes them really nervous to have OB patients show up there. So Group B Strep screening, this has changed the way we treat patients over the last 20 years. It used to be that we just periodically check certain individuals. Nowadays, it's recommended, with few exceptions, that all pregnant women between, it used to be, as of 2 months ago, 35 to 37 weeks, and it had been 35 to 37 weeks for 20 years, but it just changed 2 months ago to 36 and 38 weeks. Why? Because Group B Strep is a bacteria that affects up to 40% of women, but it comes and goes. It only lasts in its host for about 5 weeks. It's common in the digestive tract, and where the digestive tract is so close to the genitourinary tract, you can get some normal bacteria there. So it is a normal bacteria, but it can cause problems during pregnancy. Specifically, if it's untreated, the likelihood of passage to baby is about 50% colonization. And of that 50% who are colonized with group B strep, 1% can get deathly sick. They can develop pneumonia, sepsis, meningitis, and other significant life-threatening abnormalities. So what do we do about it? We recommend screening all of our patients. It's screened with a little swab. There's an example on a picture on the right side of your slides, between 36 and 38 weeks in your OB provider's office. Keeping you modest, we give you a towel, and then it goes just in the outer 1/3 of the vaginal opening. We try to be gentle, knowing those tissues are tender and oftentimes a little swollen, and then around the rectal opening. We send that to a reference laboratory. Usually we have the results within a week. If it's positive, you've done nothing wrong. It's not a sign of poor hygiene. It's simply bacteria that's common in many individuals, and we treat it with antibiotics 4 hours before delivery. By treating with 4 hours, we can reduce that incidence of colonization from roughly 50% down to less than 3. So it really has revolutionized and changed. Induction of labor is something that's received a lot of attention in recent years. In Rexburg, about 80% of our patients coming to labor and delivery are first-time moms, and we refer to them as prima gravidas, Latin for first-time mom. And so it used to be when your moms and grandmas were having babies that they say, don't be induced before 40 weeks. And that used to be true based on the perception that an induction means to give medications or have intervention that could help to put your body into labor. The concern was that if a first-time mom or others were induced before their due date, it could increase their risk of having a C-section and a baby that has to go to the NICU. A lot of that was also based on pressure that OB providers felt to get baby delivered in a certain time interval. It was considered failed if she wasn't changing an hour or a centimeter an hour. Fortunately, we have literature on our side to support the OB provider and be more patient with that individual. Consequently, 3 large studies, which were published 2 years ago, have shown that women, prima gravidas or first-time moms, who are actually induced between 39 and 40 weeks are actually less likely, not hugely so, but enough to be statistically significant, of being less likely to have C-sections and NICU babies. Now, that doesn't mean you have to do it, but that's something that will likely be discussed by you and your provider. And so for that reason, I'm pretty proactive, make that available, never force my patients to, but many like the idea to be able to plan. What are the pros and cons of induction? So the pro is it can actually now help to reduce the risk if done properly. Con is most women will say they're more uncomfortable. Why? Because there's a longer interval from the time of check-in to baby being born in most cases. Oftentimes with a first-time mom, we may bring her in the night before, give something to soften the cervix. We'll talk about that, and she may not be having a baby for 24 hours. Doesn't mean she's in labor. Labor is defined as contractions every 2 to 3 minutes with cervical change. Labor may not start until 6 to 8 hours before delivery, but it takes some time to kind of get the body in motion, as compared to the woman who shows up already in active labor. So who would benefit by inductions? Many who are interested. Who wouldn't? Those who are really wanting to have a less interventional, less hands-on experience, maybe not wanting an epidural, which we'll talk about. They may be better to give yourself a period of time. But we do like all women delivered before 42 weeks. Studies show that baby has a higher rate of stillbirth, meconium aspiration. And so oftentimes we're having this conversation, if you haven't delivered by 41, having a time that we can deliver before 42 weeks. What are factors associated with a more successful induction? A Bishop score is referring to the dilation, how dilated the cervix is becoming. Usually starts out at fingertip to 1. When you deliver, it gets up to 10 centimeters. Effacement refers to not the softness of the cervix, but rather cervical length. For demonstrative purposes, I'll pretend this is 4 centimeters, it's not. But when you're not pregnant or when you're early pregnant, the cervix can be about 4 centimeters thick. We call that 0% effaced. As you get closer to labor and delivery, it may shrink down to 3. We call that 25% effaced. 2 centimeters is 50% effaced. 1 centimeter is 75% effaced, and paper thin is 100% effaced. So that's also a fact that we're checking when we do cervical exams. In station is usually numbers -3 to +3, refers to how far up or down in the pelvis the baby is at. Historic factors that are used were fetal fibronectin and cervical length by ultrasound. Really not using that as much unless we're concerned about preterm labor. Methods for induction are as follows. I've made some bullet points for you to follow. These are things that are kind of popular today. natural measures, if you will, things that you can do in the privacy of your own home. We recommend not doing these before 37 weeks, which is when you consider term intimacy. Can have some effects. Just the biomechanics of intercourse can cause some cervical stimulation to cause you to naturally release prostaglandins. Semen has prostaglandins also, as well as some white cells that can cause some inflammation, irritation, and may help to increase the likelihood of going to labor. Breast stimulation, not in a sensual way, but it can actually help the body to release its own oxytocin, if you will, can cause some contractions. And there's some midwife literature that supports the use of red raspberry leaf tea or even hibiscus. Things less popular today are things like castor oil. Again, consult with your OB provider, see what their comfort level is with these measures, but those are some things in the natural literature, if you will. Membrane sweeping is a popular technique that can be offered after 37 weeks. Also known as stripping the membranes. I like to call it membrane sweeping because it sounds less violent. What happens there, the biomechanics of that process, if this represents your cervix, physician's gloved hand can go through the vagina and gently stimulate that, and much like intimacy, it can help to release prostaglandins of the cervix, which can increase the likelihood. There's a perception by many of my patients that they think if they get cervical checked, they're going to go into labor that night. Rarely is that true. Oftentimes people hear anecdotally from their aunt or their sister or friend, she got her membrane stripped and she had a baby that night. What's often not shared is there may have been some cervical checks that led up to that point in time. So in our office, we offer that, make that available after 37 weeks, once or twice a week, and it helps to significantly decrease the likelihood of having an unfavorable or non-dilated cervix by the time it's getting close to either induction or 40 weeks. Mechanical dilation, if you're brought in for an induction, is a non-medication option. Some of my colleagues in other OB offices in our community use this. They can put in a Foley catheter, which is a sterile plastic silicone tubing that's inserted past the cervix, and then the balloon on the end fills up, and it can be brought back to put some pressure against the cervix. Some of us will use it in the hospital. There's what's referred to as a Cook catheter, where there's a balloon that fills up on the inside and the outside of the cervix and can squeeze together to put mechanical pressure to increase the likelihood of the body going into natural labor on its own, hormone-free. Pros and cons, it's effective without medications, can be taken out in time. It does seem to be a little bit more uncomfortable. For those whose cervix isn't super dilated, oftentimes we'll bring those individuals the night before, give a medicine that helps to slowly soften or ripen the cervix, if you will. I've had great success with Cytotec, also known as misoprostol, and oftentimes we can help those patients get some reasonable rest the night prior and then hit the ground running the next day. Amniotomy refers to the procedure where an OB provider uses a sterile instrument that resembles a plastic crochet hook. It's safe if performed properly to not hurt mom or baby other than the discomfort associated with the cervical exam, and it creates a small opening in that amniotic sac. You can see from this pictorial example of how that's properly performed. Why do we use that as an adjunctive therapy? It can let the fluid out, help to increase the strength and the frequency of the contractions, and as I like to share with my patients, helps you to become less pregnant. And then lastly, Pitocin. It gets a bad rap. It is a good medication, safe, can bring about contractions. It gets a bad rap because it's uncomfortable, but most of my patients who've had experiences either way say labor's uncomfortable. And so those are some things that can be done to either initiate labor, we call induction, or if you come in contracting, to augment the labor that you may be in. Episiotomy is just a slide. They're rarely done anymore. I shouldn't say rarely, but they're infrequently, and OB providers know that we're discouraged or encouraged not to do them as frequently as they once were. What is an episiotomy? I didn't put a slide on for this one, but it's when during the delivery, if there's concern when head is coming down, that it may be better to cut below that perineal skin. If you don't have an epidural, the provider might place an anesthetic. It used to be a mainstay of delivery. It's now discouraged for this reason, that there was good evidence that avoiding it can decrease the perinatal trauma. But there are times that your OB provider may feel it's in baby or mom's best interest to do that to create more room to help alleviate a shoulder impaction issue or help to expedite the delivery because of non-reassuring heart tone. So it just encourage you to have an open relationship of trust with your provider, and we as providers are doing our best not to do them non-judiciously. So be reassured that episiotomy is not a mainstay of most prenatal care by most providers these days. I like this quote under the auspice of pain management. If pregnancy were a book, they could cut the last 2 chapters. And or they would cut the last 2 chapters because it's often overlooked. And so what are the pain medication options that can be given to alleviate that discomfort during labor and delivery? From the oral, IV, and inhaled routes, they are as follows. Tylenol, also known as acetaminophen, can offer some benefit. Norco, also known as hydrocodone, and Tylenol or acetaminophen can help. Keep in mind that Norco and Percocet are narcotics, which can have an effect on you, can be a little sedating for you and a little sedating on baby. They are safe when used properly, but it is important to know that if you already have a baby that doesn't have the most variability in heart rate, it could cause baby to be a little bit more chill. And so just a mild risk associated with that. IV medications, the benefits there, it's more rapid onset versus not waiting 30 to 45 minutes for your body to absorb the oral. Downside, it is a little stronger. And so some names that you might hear around also narcotics are Nubain, fentanyl, morphine. Purposely left out are anti-inflammatories as a general rule. We've avoided those in pregnancy. Can they use sparingly and infrequently? Probably so, but there's a concern it could cause one of the vessels in the heart to prematurely close if used frequently and often. So that's why we avoid anti-inflammatories. New to the table that we've started using at our facility in the last 3 years is nitrous oxide. Also known as laughing gas in your dentist's office. We don't really call it there. I don't know that most people are laughing through labor and delivery, maybe some. But it can be placed safely to help to take the edge off for those who aren't wanting any other form of pain control options. It's helped some. It's not perfect, but can take the edge off. Also, under invasive options, epidurals, highly discussed, highly utilized in this area. They're very safe, they're effective. Women choose not to do them for different reasons. Some want a natural experience for natural sake. Some are worried about the discomfort of the spinal needle. Most women say it's actually surprisingly and pleasantly not as uncomfortable as they thought. There's a little sting as the skin is numbed up and it's placed by one of our excellent anesthesia providers. It is safe in the sense it's not going to cause paralysis. A rare subset can get some headaches afterwards. What are the pros and cons? It can significantly decrease the discomfort of the labor and delivery experience. Downside, the biggest downside is it does not, it doesn't increase your risk of a C-section or NICU baby as previously thought, but it can prolong your delivery time. And so if on your own you would have delivered at 6 p.m., it could increase the likelihood of delivering closer to 8 p.m. So it has been shown to do that, but not increase your risk of a C-section or NICU baby. Why does it slow down? Just because when it's time to push, it may not feel as well. To help. I'm going to put in a shameless plug for Mass and Memorial Hospital where I deliver. Our anesthesia department is fantastic. They do a wonderful job at doing what might be referred to as the walking epidural. You can't get actually up and walk, but they just do such a great job where most of my patients have awareness of their legs, awareness of the contractions, but the discomfort is significantly reduced. One thing I'd also say, those who want to have a natural experience with that epidural, occasionally they have a difficult time controlling the effort by which they push and just want to push really hard towards the end. And occasionally that can result in a little bit more perineal trauma and vaginal trauma. It always breaks my heart when they've done an amazing job pushing out baby naturally, and then we're having some difficulties with pain control, getting a proper repair afterwards. Lastly, CAM stands for not somebody's name, but complementary alternative medicine. Hypnotherapy has become popular in recent years, and when done properly with proper training, can be helpful as a pain adjunct there. C-sections are a component of delivery care. We don't often do those just routinely, although if you had a previous, that's a discussion for another day. Some are choosing to do electives altogether. It's a discussion, but when do we use those? Primarily, there are certain indications, such as a breech baby. It's less safe to deliver non-head first. If the placenta is in the front, it would be dangerous to deliver vaginally. If while in labor, despite appropriate interventions, the baby has failed to drop down in the pelvis, the heart rates are non-reassuring, baby's in a position that's not conducive to vaginal delivery, those could be indications. Right now, the national incidence of a cesarean section is 31%. Some areas higher, some lower. We're blessed in our area that 10% of our first-time moms have C-sections versus 30%, 20% overall that account for the repeats. And so it is a wonderful tool to have to save babies' lives, but it's not something it's something we don't just usually do because we've got golf time in 5 minutes. It's something we do for those indications. What are the benefits? It can help to get a baby alive and well. There also could be less trauma in the pelvic floor. If you're a mom who's had a vaginal delivery before and you had significant injury, a 3rd or 4th degree repair, that can take a long time, as you know, to recover. And there are some benefits that show a repeat section or a primary section could help to, the benefits of a section could outweigh that. And also, if you have diabetes or gestational diabetes or and your baby's estimated to be a certain weight, there are some benefits in doing a primary section. And so that's a discussion to have with your healthcare provider. What are the adverse effects? It is, even though it's probably the most popular, I think it is the most popular surgery in the United States today, it is a surgery. And so with surgery come increased risk of bleeding, infection, and injury to adjacent structures, and it can take a little bit longer to recover. Breastfeeding, super important. We would never want our moms to feel bad or guilty if they're not successful in breastfeeding, but it is something that we encourage and we rally around you to provide resources. We have dedicated lactation nurses to help out with that. It can help babies be adequately nourished. They're less likely to get certain infections, less likely to be colicky, less likely to be constipated, maybe even less reflux, less likely to get certain infections, including RSV, influenza, and who knows, maybe less likely to get COVID-19, too early to tell. And it also can help moms be healthier too, get back in their skinny pants faster, and reduce their risk of diabetes and high blood pressure. Skin-to-skin contact is something we encourage after you deliver. I didn't do a slide for this, but if all is well, we are huge fans of delayed cord clamping at our hospital, as that can provide babies some additional oxygenated blood. And then skin-to-skin can have several benefits, including increasing success of breastfeeding. Among the last slides, it's important to follow up with your healthcare provider after delivery as instructed. Oftentimes, around 6 weeks after vaginal delivery, we'd like to review, and sooner if we see any signs of postpartum blues and depression, which is pretty common during the recovery stage. About 20% of women will experience that. The biggest risk factor is sustained sleep deprivation, so trying to get adequate rest. Encourage you to sleep when your baby sleeps. Stock up on frozen food, paper plates, let the kitchen and the bathroom go, and focus on rest so you can take care of your baby. We talk about, see how things are going with breastfeeding. We talk about contraception. Even those who are zealous and want to have a zillion kids, which is admirable, we do recommend giving your body some time to heal. If women conceive before their baby's a year old, there is a slight increased risk of miscarriage and preterm labor. So we talk about that, not that we're judging if you conceive sooner than that. We like to make sure things are proper healing. We talked about intimacy changes that can occur after you've had a baby and when it's proper to return to work. So that is 3rd trimester in prenatal care. We appreciate your attention, and if you have any questions, concerns, please reach out to us or to your healthcare provider. Thank you.